Okay, this is, I'm working on this project, and this is to start creating new questions and new objectives for material. Since I can't use past tests that I wrote or used, we'll use this. Now, this is the kind of the opening statement. It says, given assessment questions of various types, such as multiple choice or true false or multiple true false or multi-answer or matching or whatever type of question I can think of, the student will be able to discriminate between the correct information and the distractor information and select the best answer with an accuracy of greater than 80%. Of course, I'd like for you to do 100, but that's not a practical goal. So I said if you can do 80, you can do well. And these are some of the questions, and I'm going to do this for the entire piece of information on bland aerosol therapy. This is all I could put together last night. First of all, you have indications. Let me see if we can zoom in on this. What we call the indications for bland aerosol therapy. First off, it's what we call, now this is referring to cool aerosol, and that cool aerosols are used for treatment of edema, swelling of the airways. The study guides and all the books that you look at always cover these, and this is also comes from the AARC information, the American Association of Respiratory Care, is to treat or reduce swelling, airway edema. So when there's presence of upper airway edema, we use cool aerosol. If there is, now that includes upper airway and lower airway. When you give this, no, that's just upper airway, excuse me. Then we have what we call subglottic edema. That means where does the glottis start? The top of your larynx, that opening. So anything below that, that is edematous, we could give cool aerosol for. Next is what we call, yes? Huh? I said subglottic edema. Anything below the glottis is what we would give cool aerosol to help that. So we would typically give it with a face tent, for example, or an aerosol mask. Then there's an extra category called post-extubation edema, meaning when a breathing tube is removed from a person's throat, their throat is a little swollen because it's not normal to have a tube in your throat. And it's there and it irritates the throat, and the person, once they pull that tube out, their throat hurts. And the cool aerosol is soothing to that. So a little bit more about aerosols. We give aerosol hot or cold. You would never give a hot aerosol to a person with a swollen throat. It would make things worse. So we give cool aerosol for edema. Another category is laryngotracheobronchitis, a bronchitis of the larynx and the trachea. That airway, when a bronchitis occurs, the airway is swollen. And it gets edema, so we would give it for that. The next phrase, postoperative management of the upper airway. Once again, this is referring to somebody who's coming out of the operating room, and while you're in the operating room, you're going to be under some anesthetic of some type. And if that is the case, they're going to have some apparatus in your throat. Whether it's an endotracheal tube or a laryngeal mask airway or an oral pharyngeal airway, some apparatus would have been placed there in your throat. All of those create swelling if you leave them there long enough. They all create discomfort. And you would need that cool aerosol to soothe that airway. Next, presence of a bypassed upper airway, and this means it has to be heated. Whenever you apply aerosol to an airway and the upper airway is bypassed, when I say the word upper airway, I mean from the tip of your nose to the top of your larynx. That's your upper airway. When you bypass the upper airway, you take away the person's ability to warm, to filter, and to humidify that gas. We need your brain, your upper airway does that so efficiently. By the time you take a breath from the tip of your nose to the top of your larynx, it has almost all of the humidity it needs, and it's been filtered and warmed. So if you're at 32 degrees, by the time it reaches the back of your throat and you inhale through your nose, it's almost warmed up to body temperature. It's almost taken on all the humidity it can. So when you bypass that mechanism and you go straight to a tracheostomy, you have to warm that air, and you've got to provide that humidity. If you don't, you have a humidity deficit. Humidity deficit, once that occurs, the airway begins to lose its function, and the mucociliary escalator comes to a halt, and sputum, phlegm, begins to be retained, and bacteria start to grow, and then the airway starts to dry out and plug up. So anytime you bypass an upper airway, you've got to provide heated aerosol. But if you're going to provide aerosol, if you're going to provide humidity with a heated humidifier, that is always the better choice. But most often we don't have that option to provide heated humidity for a short-term hour or two. So that's why we use heated aerosol instead, because it's disposable. Now, general goals of aerosol therapy. And when I say aerosol therapy, I'm not talking about, another word for this is called bland aerosol therapy. I know that sounds strange, because we usually think of the word bland as referring to a food. We don't think of a liquid as a bland liquid. At least I don't. Bland means it doesn't taste good and I don't want to eat it. Oh, here's rice. Okay, oh, no salt. Sorry, it's bland. Not kidding, it's bland. It's awful. Put some salt and butter and pepper on it, some Tabasco sauce, and now we're getting somewhere. Okay. So, in this case, they mean bland, meaning it is sterile water or saline. That's what they mean when it's bland. The other thing in the aerosol world we give is hypertonic saline. And that is only given when we want to induce a sputum in production. But when we give hypertonic saline, we run the risk of causing bronchospasm and bronchoconstriction. So that's a whole nother concern. So for the most part, when you hear the phrase bland aerosol, it means it is sterile water or saline, but it is not hypertonic saline. It is not water with Tabasco sauce in it. It is not water with salt it does have salt sometimes when it's saline. The general goals are to improve bronchial hygiene, to improve the efficiency of the cough mechanism, to restore and maintain normal function of the mucociliary escalator, and to humidify gases to delivered patients with artificial airways, to humidify gases to an artificial airway. That's the only one that has to be heated when it's an artificial airway. Now, bronchial hygiene, I actually should put, bronchial hygiene should be one, and then I should put to improve the efficiency of the cough mechanism and to restore and maintain normal function of the mucociliary escalator under bronchial hygiene. They really should be subsets of that.
Say that subsets again.
Meaning under a heading. In other words, bronchial hygiene is about coughing. Bronchial hygiene is about improving the mucociliary escalator. That's what the only two things you do in bronchial hygiene is you're working on those things. So bronchial hygiene sounds funny to you, doesn't it? Oh, like oral hygiene where you brush your teeth, or the thing is we don't think about bronchial hygiene because our body does it for us. We don't have to worry about it. But there are a population of patients that we have to do bronchial hygiene therapy every day or they are not going to live. So that's it. Bronchial hygiene means helping their cough to be effective. It means helping them to expectorate sputum from their lungs, and particularly some diseases, their lungs are just clogged with it. And they have to have bronchial hygiene every day, every so many hours. Somebody has to do this for them. How does aerosol improve the efficiency of the cough? Well, for one thing, aerosol will wet down the epithelial lining. It wets down the layer of secretions that line our airways, which makes up the mucociliary escalator. And you need that. If you don't have that, your airways will clog up and you get mucus plug formation and you end up having big chunks of lung that don't get ventilated. So improving the coughing mechanism and improving the mucociliary escalator are really subsets, are parts of bronchial hygiene. And we don't think about it when we do it, but other people need help to do that, and aerosol helps that. Planned aerosol therapy, what we call contraindications. One is bronchoconstriction. You can give an aerosol to a person and you don't hear any wheezing. And 2 hours from now you start hearing wheezing. Wheezing is evidence of decreased lumen size, and aerosol can cause that. Aerosol can cause the smooth muscle to react and tighten and cause bronchoconstriction. If that, you always are suspicious that that could happen to a person. So that's why whenever you start somebody on aerosol, you always monitor them carefully to see how they're going to respond to it. You cannot assume they're going to be okay with it until you give them some time and assessment to know that it's going to be okay. That is more of a risk if it's hypertonic saline or something with a salty content in it. The other contraindications is a history of airway hyperresponsiveness. Airways respond to stimuli. When you go out and you are vigorously exercising, your airways dilate so that you can ventilate better. When you relax and you sit down and you're having dinner, your airways will reduce their diameter because you don't need that big of an airway and the muscles can change shape. So the airway is always moving. You have parasympathetic and then sympathetic responses that change its diameter. So we all change our airway diameter. But some people's airways are hyper. And where they're hyper responsive, they get stimulated and they contract really tight and really quickly. We call that hyper-responsiveness. People who have hyper-responsiveness, that's the other word we use for a patient with asthma. They have a hyper-responsive or hyper-reactive airways disease. That means asthma. Therefore, when you're going to provide aerosol to a patient, you need to look at their chart to find out if they have a history of asthma. or they have responded badly to aerosol in the past. You read, oh, when he was admitted last time, he had to be, we couldn't use it because he had a bad attack to it after he had had it for just 2 hours. So that's a hyperresponsive response to aerosol. So when you typically hear hyperresponsiveness, you think of past history of responding to it badly, or they already have asthma and their airways tighten quickly and irrationally, very quickly. Now, hazards and complications. Edema of the airway wall itself. Edema is associated with decreased compliance and gas exchange and with increased airway resistance. Whenever you hear that a person's airways are edematous, if you've ever seen them on bronchoscopy, they look red and inflamed and they're swollen. And if the physician, the pulmonologist, touches that edematous airway with the tip of his bronchoscope and then lifts it up, you will see that it weeps liquid. It actually, you press into it and then you release it, and you can see where they pressed it, there is a pooling of liquid will show up as a result of being touched. They actually refer to that as friable. It will, you touch it, it might even bleed or just weep liquid like plasma, but it's very sensitive and swollen. Yes?
What did you call that again?
Friable.
Friable.
Like you fry an egg.
Yeah.
It's a funny phrase. I don't get it, but it's friable.
Maybe it's like when you burn yourself, how red it is.
That might be, but I know that I've heard that phrase used.
Delicate.
Huh? It's delicate. Yeah, it's touchy. Okay. What causes the airway to become edematous as a result of aerosol therapy? That usually goes with heated aerosol, particularly when the aerosol is too hot. The heat causes the airway to swell. The heat causes the airway to have edema. Next, caregiver exposure to droplet nuclei. You're the caregiver. You're there working in close proximity with the patient. The patient has aerosol going in their airway, and then that aerosol floats back out when they exhale. If they have a particularly lung infection and they inhale and then they exhale, could bacteria have attached themselves to those little droplets of aerosol that are floating out into the room? Yes. Do you want to breathe them? No, I don't want to. One thing you'll never see them do is willfully put an aerosol on a patient with tuberculosis, because that adds a really good way to spread tuberculosis. TB is very, very, very small, and it itself is so tiny, it's closer in size to a virus than a bacteria, and it can float in the air for hours just waiting for somebody to go by and inhale it. They're sneaky little devils, and they float in the air for hours. Yes?
So we should be wearing droplet precautions standard for when we give blended aerosol therapy, correct?
Well, that's a rub there because we typically don't. And quite honestly, you're probably not going to experience it if you feel like you need a mask, wear a mask. If I'm in there doing aerosol and changing out equipment, which I haven't done in years because I always get the students to do it because that's why I'm there. I'm not there to do it for them. So you might be the one to want to put on the mask. I almost stand 6 foot away. But the point being, when you're working with aerosol and there's a known upper airway infection, you should probably wear a mask. If you know they already have a gram-negative pneumonia, I'd put on a mask.
Okay, so that's now for testing matrices for the national boards or for anything that you do, it would just be standard precautions?
Well, you wear your gloves
Right.
always. Anytime you're working with aerosol or anything like that, you always wear gloves. That's probably all you should answer unless they say it known to have such and such an infection. Next, patient discomfort. Wearing an aerosol mask is not comfortable. You don't do it willfully for fun. And it's not comfortable. The patient just can't stand wearing the mask and having that aerosol blowing in their face, and it's noisy. That's a hazard, and you probably should stop it, or at least let them take a break. If that's the case, and they need to keep taking it off, and you're only giving it for humidity purposes, have them take their oxygen with the nasal cannula, and then use the aerosol as room air as its gas source, so they can get humidity when they need it or feel like they need it, and then take it off when they're unhappy with it. But don't then link their oxygen supply to it, because they'll be taking it off. Overhydration. These aerosols produce a lot of moisture, and moisture soaks through the lungs into the bloodstream, so you can overhydrate a lung. However, this problem primarily exists with neonates and infants. It's very rare for adults, but an adult that I would not do this for is an adult who already has fluid overload. They already got too much fluid in their body to begin with, and we're trying to help them get rid of it. Why would I give them more fluid into their lungs if they've already got too much? So that's an adult case where you don't want to overhydrate that person. They're already too overhydrated. Associated more frequently with the use of ultrasonic nebulizers than with the use of jet nebulizers. Ultrasonics produce about 3 times as much output as a jet nebulizer. They really can pump out the liquid. Aerosols generated with the ultrasonic system, the aerosol is very dense and has a lot more aerosol in it than your standard pneumatic jet nebulizer. So they produce a lot of aerosol. Ultrasonic systems are used for providing mist for mist tents. When you want to set up a mist tent for a child who has croup and you want it to be a cold mist, use an ultrasonic system. That will really pump out a lot of aerosol and make it very dense, a cool, dense aerosol to help treat croup, for example. Using ultrasonics for humidification on an adult is not done except for cases when you need to give hypertonic saline and you want to induce a sputum, what we call sputum induction, so we can get a sample and we can assure that it comes from deep in the lungs, so the sample is going to be taken for bacterial examination and for looking for cancer cells, for cytology, for example. Next, bronchoconstriction, bronchospasm, and wheezing. Most common in asthmatic patients, and it may result in hypoxemia. Bronchoconstriction can come from the aerosol. It can cause it. And when it happens and you get bronchoconstriction, the physiology ends up that the person gets hypoxemic, and they end up having to breathe faster because of it. So if you see a patient who's on aerosol and they were good and now they looked good by exam and by assessment, and an hour later they're short of breath and they're anxious and you listen and they're wheezing, it's most likely the wheezing was caused by the aerosol. But I need the caveat there is it might mean that you're accomplishing your goal too. Your goal meaning not to cause wheezing, but the other thing it has is the sponge-like effect. Imagine you have a dehydrated patient. This is common. you give them aerosol, and an hour later they start to wheeze and you hear some rattling going on. Should you stop the aerosol? Answer is no. What you need to do is that's the time you need to start bronchial hygiene. You need to get them coughing. You need to get them to expectorate phlegm. What happens is you have dried phlegm in your airways, you add water, and what does it do? It changes volume, it swells. It's like a wet sponge, it gets bigger. You need to clear that out with coughing and deep breathing exercises or other bronchial hygiene techniques we do. And if they're wheezing and you think it could be bronchospastic, you should, and smooth muscle related, give a bronchodilator, and that would further help. That would really help dilate the airways. So then you can clear out the person's lungs. Dehydrated patients, even though in our modern society, happen all the time. Especially in the summer, people get dehydrated. They don't drink enough water and they're working outside. Or another classic, they're elderly and they don't like to drink fluid. I know some older people that hate to drink liquids. And the only thing they like to drink is iced tea and soda. Huh?
And hot coffee.
And hot coffee. Give me tea, give me hot coffee, and give me Pepsi. But don't give me a glass of water. I drink water all day, but it's funny, I really hate the smell of spigot water that comes out of spigot because it has that chlorine smell in it. So I buy gallons of distilled water. I'll go to Walmart and buy 40 gallons of distilled water, put it in the garage, because that's what I prefer. They used to deliver it to my house. Now they charge a fortune. So I said, get that. It turned out to be like $3 a gallon. I said, no, that's more than milk. I'll just go and buy it from Walmart. But the point is, my dad doesn't like to drink water, so I got him distilled water. He still doesn't like to drink it. Tea, he's good with. You know, he likes tea, but not water. So you will see dehydration quite frequently, particularly coming in from the ER, particularly when they're elderly, because they don't like to drink water. Okay. Did we cover all that? Okay. We'll stop that. I'm actually trying something new. I like to record